Welcome to the body imaging cases. Here are two different patients with strongly enhancing lesions on the arterial phase of contrast-enhanced CT, both related to the pancreas. The final diagnosis of the first case was Castleman's disease of a lymph node intimately related to the pancreas, to the degree that it was mistaken for a pancreatic neoplasm. The final diagnosis of the second case was ectopic intrapancreatic spleen. Both patients had contrast-enhanced CT and gadolinium-enhanced MRI, and in both patients, the enhancement of the lesion on CT was extremely higher to that of the normal pancreas compared to the MRI, on which the enhancement difference between the lesion and the pancreas was not so striking. This is the first case. The lesion became strongly hyperdense to the pancreas after injection of the contrast agents. On the MRI, however, the lesion became only slightly hyperintense to the pancreas. This has nothing to do with the phase of enhancement because both images were acquired at the same phase. And it has nothing to do either with the fact that the pancreas has inherent high signal intensity on the unenhanced T1-weighted MRI because the lesion and pancreas are more or less iso-intense also on this subtracted image. The same happened in the second case. Here are the unenhanced images, and the lesion became obviously hyperdense to the pancreas on the contrast-enhanced CT and just iso-intense on MRI. It is the same arterial phase of enhancement, and again, the appearance is more or less the same on the subtracted MRI image. What is common between the two lesions that may be responsible for this phenomenon? The Castleman's disease and the ectopic intrapancreatic splenule. Both have ample amount of intravascular space. We know that enhancement happens because organs or lesions receive the contrast agent first in their intravascular space, then subject to permeability and pressure among other factors, the contrast agent seeps into the interstitial space. Wash in and wash out are faster, of course, in the intravascular space than the interstitial space. Why then is the enhancement of these two lesions relatively less in MRI than CT, although it is known that MRI is more sensitive to its contrast agent, gadolinium, than CT is to its contrast agent, iodine. And although it is frequently said that the distribution of the two types of the contrast agents in the intravascular and interstitial spaces is similar, here there are two factors. First, the gadolinium contrast agent moves into the intravascular space of the lesion more than it moves in the tight interstitial space, and this movement is responsible for dephasing and a certain degree of signal loss. Second, gadolinium arrives in higher concentration into the intravascular space, and this is responsible for higher T2 effect, which reduces the signal intensity even on the T1-weighted images. Iodine contrast agent, on the other hand, has nothing to do with these two factors. Whether moving or not, iodine will have the same density, and higher concentration of iodine absolutely means higher attenuation value without any paradoxical effect. What is the practical point? Whenever you see a lesion which is more enhancing compared to its background on CT than on MRI, think of a lesion with large volume of intravascular space. In the first case, Castleman's disease, though rare, may be prioritized over solid pseudopapillary neoplasm. And in the second case, ectopic spleen is to be prioritized over neuroendocrine tumor. Splenic tissue is largely composed of intravascular space, and nothing is more impressive here in favor of this issue than a comment made by an eminent hepatobiliary and pancreatic surgeon on the ectopic intrapancreatic splenule intraoperatively. Before resection, it can be felt as a lesion while it is engorged with blood. After resection, it gets collapsed and cannot be felt within the resected specimen to the degree that the surgeon may doubt if it has been really removed. Clear with the splenule? What is the story of the first lesion then, the Castleman's disease? It has also ample intravascular space, particularly the vascular hyaline type, which was the exact histological diagnosis in this case. Let us have a closer look at the contrast-enhanced CT of this case. A strongly enhancing lesion at the undersurface of the pancreatic body. And here is the 3D reconstruction of the CT angiography. Showing a large volume of intravascular space, making the largest part of the lesion. And fast draining into large tortuous veins at the periphery of the lesion. So the learning point here is that higher enhancement of a lesion compared to its background on CT than on MRI is indicative of its large volume of intravascular space. This may be a useful clue to narrow the differential diagnosis in certain situations.